Hello and welcome to everyone. We are here for the first World Anesthesia, first day of Regional Anesthesia and Pain Medicine webinar. We are going to give a few more minutes in case more participants are going to join us. So just hang tight. We are all here and just give a minute for people to join in. So we have participants joining. I can see about more than 100 and the numbers are going up. So I'll give them another few minutes to join. So when I open up the chat box, can you guys see my chat box there or not? Yes, okay. So I should stop opening that chat box, I suspect. Right, let's just get started in the interest of time. Thank you, everyone, for joining us. This is the webinar by the Canadian Anesthesia Society as a part of a bigger event, which is organized by which is led by the European Society of Regional Anesthesia, which is the first World Day of the regional anesthesia and pain medicine. We have an impressive lineup of speakers, and over the 90 minutes will make it worthwhile for all of you. I'm pretty sure we are all in different time zones, so my time zones are just going to be referring to Eastern time zones when I'm talking about the times of in here. Right, let me see if I can advance the slide. Perfect, yeah. So first of all, I want to thank the Canadian Anesthesia Society to give this to all the participants for free, and normally it is charged and it's only available to the Canadian Anesthesia Society members. So thank you for doing that to make it more publicly available to everyone. And also Ezra for making this big initiative there for us. I'm going to be the host. I'm an anesthesiologist and I work at Halifax, Canada, at Dalhousie University. I have a couple of conflict of interest. I am currently the chair for the Regional Anesthesia and Pain Medicine section of the Canadian Anesthesia Society, and also serve as associate editor for the Canadian Journal of Anesthesia, which is the society journal. We usually start with the land acknowledgement, which is going to be a bit unusual for others. And I'm not allowed to paraphrase this, so I'm going to read a couple of lines from here. Many of us are joining today, meeting from lands across North America. North America is known as a turtle island by many indigenous communities. Let us acknowledge the land we are meeting on is the traditional territory of many nations. Specifically, where I am is Halifax is located in the Mi'kmaq, which is the ancestral and traditional land for the Mi'kmaq people. So we have a busy agenda today. After this brief introduction and housekeeping, we will have a welcome message from Dr. Mocha and Sebastian from the European Society of Regional Anesthesia, who are the main organizers for this event. And then we have four quick talks talks on very high-yielding topics by expert speakers. The first, which is each 15 minutes. The first one is on regional anesthesia for shoulder surgery, followed by spinal anesthesia, drugs and recipe. The third one is on regional anesthesia for trauma and emergency room. And then the final one is on pediatric regional anesthesia. We will have the Q&A session towards the end. There's also a Q&A chat box there, and there's also a chat box which is separate. So I would encourage you to use Q&A section if you have any questions rather than the chat box which is there. So, and we will try to answer as many questions as possible. So it's going to be 90 minutes and we have a jam-packed agenda. We'll have a lot of opportunities to answer your question through the panel towards the end. Just to remind you, we have the annual Canadian Anesthesia Society meeting, which is happening this year, June, in British Columbia, Victoria, which is a beautiful city. So if you can join us, it would be an amazing thing to do. We also have regular webinars, which we offer for the society members. The one in January is about airway training. There are two in February. The first one is about tips for getting published in the CJA from our editor-in-chief, and also on neuroanesthesia, which is later in February. And then finally, we have in March on perioperative mental health webinar. Our first speaker is Dr. Patrick Wong. He is assistant professor at University of Ottawa. He's also the lead for the regional anesthesia program at the Ottawa Hospital General Campus. And he will be talking to us about evidence-based regional anesthesia for shoulder surgery. Our next speaker is Dr. Kwesi Kwofie, who's an associate professor at the same institute as I am. He's actually the head for the regional anesthesia division of our section. And he's known for his very thoughtful talks and insights. We have regular friendly arguments, which we are very well known for. So I'm very looking forward to this talk, especially. And he's going to be talking about spinal anesthesia, drugs and recipes. And then we have Professor Vivian. She's joining us from University of Calgary. She's our incoming chair for regional anesthesia section. I have to mention that both Dr. Wong and Dr. Kwesi have been to the previous chairs of our section. And she will be talking about the regional anesthesia techniques for trauma and emergency room. And last but not the least, Dr. Ushma Shah is an assistant professor at Western University, London, Ontario. She's also the fellowship director for pediatric program. And she's the incoming vice chair for our section. And she'll be talking about pediatric regional anesthesia. So without any further delays, I will hand it over to Dr. Mocha and Sebastian to give us a welcome message from the ASRA, and I'll stop sharing my screen. Oh, before I stop sharing my screen, please fill in the evaluation survey. This will provide us by doing this, you will be able to get a CME certificate and an attendance certificate. And if we are unable to answer any of your questions, feel free to ask us on X, which is Twitter previously, and we are all pretty active except Vivian, who doesn't even probably remember her Twitter handle. So we will be more than happy to answer any of the questions there. So thank you so much for joining. And Dr. Mocha and Sebastian, would you be able to share your screen once I stop sharing mine?
Thank you, Vishal. Hello to everybody attending us on the other side of the net. It is honestly a great pleasure and honor and an important privilege for me to have the opportunity to say a welcome message in this wonderful webinar that you are organizing in the broader context of the first World Day of Regional Anesthesia and Pain Medicine. This day is a newly launched initiative of the European Society of Regional Anesthesia and Pain Therapy, co-organized with all our sister societies, ASRA Pain Medicine, LASRA, AFSRA, AOSRA, and of course with the very active participation of the Regional Anesthesia and Acute Pain section of the Canadian Anesthesia Society. And we deeply thank you for being a part of this celebration of today. This webinar is the last but not least of the activities that took place from this morning all over the world. And I have to admit, I feel extremely proud and happy and honored to announce that today, including the participants that you said around 400 and something for this webinar, we reached, if not crossed, the 7,000 colleagues celebrating regional anesthesia and pain medicine worldwide. Many thanks that I have to say to everybody, to the leaders of the sister societies, to the countries coordinators, to the cities coordinators, to the leaders of the webinars that took place in various countries, but also to the people that invested their efforts to organize local face-to-face meetings with local or national faculty in the native language of the colleagues in the various countries. And just for time constraint, I would like to avoid to speak too much, but just to highlight that this event is not only an educational event. This activity is an activity that made us connect to each other, an activity that made us unite our forces, unite our individual strengths. It's an opportunity to raise our collective voice for a pain-free future worldwide for everyone, everywhere. I really thank you all for being with us today. I see in the chat that the enthusiasm has not stopped. I see participants from countries and cities where local events were organized. And before saying goodbye and a good attendance and an enjoyable webinar, I would like to promise you that I try my best to meet you in person in various activities in the forthcoming future. And I would pass the microphone to my very good friend, Sebastian Bloch, who is the heart of the organization as chair of the event. Thank you.
Thank you, Eleni. Just a few words. The first is enjoy your webinar. Everybody enjoy in the east of the world, so you will enjoy in the west, and I'm sure that you will have a success during your webinar. This event was great all over the world. So see you next year for the second takeoff of the World Day of Regional Anesthesia. So enjoy your webinar. Thank you. Bye-bye, and see you.
Thank you. Have a great attendance, and see you soon. Huh? Join our hands for a pain-free world.
Yes.
This is the message.
Bye-bye.
Bye.
Thank you so much to both of you for taking time in your busy schedule to come and speak to us in live. Yeah. Thank you. And let's get on with the work now. And our first speaker is Dr. Patrick Wong. Dr. Wong, do you want to share your screen with us?
There's a chance you might be muted.
Patrick, you're muted, looks like.
Hello, is it okay?
We can hear you for sure now.
Okay, there was technical difficulty already. Sorry about that. So thank you, Eleni, Sebastian, for organizing this wonderful event, and we're privileged to be part of this exciting World Day of Regional Anesthesia and Pain Medicine. My talk today is go back a bit. I talk today regional anesthesia application in shoulder surgeries, and I have no conflict of interest to disclose, except I'm going to be talking about some off-label use for medications. The objectives for this talk, I wanted to talk about the pros and cons for classic interscaling block compared to the newer phrenic sparing blocks for regional anesthesia or shoulder surgery, and then talk about how you might use different approaches if you're going to do a surgical block versus do an analgesic block, and also help you develop some strategy to prolong the analgesia of your block when it comes to shoulder surgeries. So a quick talk of anatomy. And so for the shoulder joint, as you know, the nerves come from the brachial plexus, but more specifically, there are 4 terminal branches need to cover for the shoulder joint itself: the suprascapular nerve, the lateral pectoral nerve, the subscapular nerve, and the axillary nerve. You need to have all 4 to cover, have comprehensive coverage of the shoulder joint. On top of that, if you're going to do a surgical block, you have to cover the cutaneous innervation as well. And there are 3 nerves that you need. 2 of those, suprascapular and axillary nerve, we looked at earlier, is part of the brachial plexus, so that's fine. But the supraclavicular nerve is not from the brachial plexus, from the superficial cervical plexus. So you have to block that separately if you want to do a surgical block. So if you're here on a weekend listening to us talk about regional anesthesia, you probably know the classic technique for shoulder surgery for regional anesthesia would be an interscaling block, injecting local anesthetic around the C5 and C6 nerve root. And you probably also know that the phrenic nerve is very close by. And so on ultrasound, this is more apparent that between the scaling muscle, you have the C5 and C6 nerve roots, and the phrenic nerve sits superficial to the anterior scaling muscle in close proximity. So depending on the volume of local anesthetic you use, invariably you'll cause some phrenic nerve block and respiratory dysfunction. And on top of that, we alluded to earlier, you need to block the supraclavicular nerve if you want surgical anesthesia. You can block this nerve by blocking the superficial cervical plexus, which you can access at the prevertebral fascia between the middle scaling muscle and the sternocleidomastoid muscle. A problem is that the phrenic nerve also sits in the same fascial layer. So another reason that you might cause a phrenic nerve block if you want to add this to your surgical block. So for the last decade or so, many studies have been published and many techniques described on how else can we deliver regional anesthesia without causing so much phrenic nerve block. And many techniques have been described, and collectively we call these phrenic sparing nerve blocks for shoulder surgeries. So instead of blocking at the nerve root, you can move a little further down the brachial plexus and block the superior trunk. And this is what the ultrasound will look like. If you move even further down, you can do the classic supraclavicular brachial plexus block at the junction of the first rib and the subclavian artery. If you move even further down, you're going to target isolated peripheral nerve that are involved. You can target the suprascapular nerve right here, or you can add to this suprascapular nerve block an axillary peripheral nerve block, which is done at the deltoid level. So how do these alternatives, phrenic sparing blocks, compare to the interscaling, which has been the gold standard for a while? I'm going to look at 4 main categories. I'm going to look at whether you can do surgery with the technique, the degree of respiratory dysfunction and analgesia compared to interscaling block, and whether a catheter technique is possible. So for surgical block, if you look at the anatomy picture again, the first takeoff for one of the 4 peripheral nerves that we need is the suprascapular nerve. So if you block proximal to that, you're going to get comprehensive coverage for your shoulder joint. So that's why interscaling blocks, superior trunk blocks, and supraclavicular blocks are all appropriate if you want to do a surgical block. But if you start doing isolated suprascapular or axillary nerve block, that wouldn't cover all 4 nerves, and then you wouldn't get comprehensive coverage for the shoulder joint. I put an asterisk next to the supraclavicular block because the suprascapular nerve takeoff is at the vicinity of this block that where you usually do it. So you got to make sure that you didn't miss that nerve when you want to do complete shoulder coverage. Looking at respiratory dysfunction, there are many studies been published about these phrenic blocks compared to all sorts of different control. I try to limit the search on meta-analysis reviews that published in the last 5 years, try to give you the most up-to-date information. When we look at superior trunk block, this meta-analysis compares superior trunk block to intrascaling block for shoulder scope. And they found that the incidence of total hemidiaphragmatic paresis and the absence of hemidiaphragmatic paresis both favor superior trunk block when compared to intrascaling block. Our group published this in 2020, looking at supraclavicular block compared to intrascaling block, and we divide the study as single shot block versus continuous nerve block catheter technique. But for both techniques, the supraclavicular approach has less diaphragmatic paresis compared to intrascaling block. Looking at isolated suprascapular nerve block, this meta-analysis published 2021, they weren't able to show data on diagnosed diaphragmatic paresis, but comparing to intrascaling block in terms of subjective dyspnea, the suprascapular nerve block is more favorable. Same group published meta-analysis on suprascapular plus X-ray nerve block. And again, they show that significantly less subjective dyspnea with this more distal approach compared to intrascaling block. So it appears that compared to intrascaling, all these phrenic sparing nerve block has benefit in terms of respiratory dysfunction. In terms of analgesia, the superior trunk block compared to intrascaling is the same meta-analysis we looked at earlier. The degree of motor block and the analgesia duration seems to be comparable between the two techniques, so no difference. For supraclavicular, again, both looking at single shot approach and catheter approach, supraclavicular and intrascaling block seems to have comparable analgesia. When we move further down and talk about isolated suprascapular, we start to see some difference in pain. Compared to an intrascaling block, an isolated suprascapular nerve block has higher pain in PACU and 1 hour post-op. However, the pain difference goes away pretty quickly from 2 hours post-op all the way to 2 days post-op. And interestingly, the suprascapular nerve block actually has less pain. The intrascaling has more pain at 12 hours post-op. And we'll talk about that, why that might be in a bit. Finally, this study, they found no difference in the opioid consumption at 24 hours between these two groups. Adding the axillary peripheral nerve block to the suprascapular block, also worse analgesia in PACU and at 4 to 6 hours after surgery, but no difference afterwards and no difference in patient satisfaction as well. So for analgesia, it appears that if you do the phrenic sparing block that are closer to the intrascaling, so the superior trunk and supraclavicular approach, you're going to get comparable analgesia, but as you get more distal, you might have more pain. However, the pain difference goes away pretty quickly in 4 to 6 hours post-op at the most. So next, I want to talk about how you can prolong your block. And before we talk about how you prolong the block, we can talk about why you want to prolong the block. This study is a little old, but I always try to bring this up when we talk about shoulder surgery and intrascaling block. This is a meta-analysis looking at single shot intrascaling block compared to placebo, so no block at all. And the intrascaling group actually has worse pain at 24 hours post-op compared to no block. And there's no pain difference after 24 hours. We think that this phenomenon is probably due to rebound pain, and we still don't know for sure how the rebound pain mechanism is, but essentially people who had no pain for a while, and as the nerve block wears off, the sensation of pain is much higher compared to you had no block the whole time. And there's also some signal that says people who had block for upper extremity surgery actually utilize the emergency department more compared to a patient with no block. This is a study from the Midwest, and they showed a higher emergency department visit on postoperative follow-up to day 1 and 2. Now, this is a bit of cherry picking of this data because there's some study looking at the same thing and they found no difference. But in any case, it makes you wonder the benefit for a single shot block. So in an ideal world, an ideal setting, you would want to do a catheter, either intrascalene or the phrenic sparing nerve block catheter. Catheter is preferred because it's titratable and you can have total control in terms of the duration. You can make it last longer, just keep giving local anesthetic, or you can turn it off by just stopping the local anesthetic infusion. So you can, if you have too much side effect, for example. But there are many technical, logistical reasons why a catheter is not feasible. One reason, in Canada, most of the shoulder surgery is done in the beachhead position. And you look closer to the surgical field, you can see that from the base of the neck all the way to the elbow is exposed. So some of these phrenic sparing nerve blocks, when it's further away from the brachial plexus, you might get in the way of the surgery. So in terms of placing a catheter, for sure, intrascalene superior trunk block, no problem. You're at the base of the neck or higher, you'll stay out of the way. But as you get to the supraclavicular approach, and further distal, you're going to be near or within the surgical field. And so if you want to place a catheter for that, you might have to have some more fancy needling approach or tunnel your catheter to stay out of the way. And for sure, axillary nerve block is not possible because you'll be right in the surgical field. So how else can you prolong the block? Many studies, again, in the past decade, looking at additives such as dexmedetomidine and dexamethasone. I struggle a bit to decide whether to include this meta-analysis because the journal seems a bit predatory and the level of details being reported is a bit sparse in this study. But at the very least, they did a pretty comprehensive research and they found evidence supporting using IV dexamethasone, perineural dexamethasone, IV dexmedetomidine, perineural dexmedetomidine, and giving both dexamethasone and dexmedetomidine IV together. All these had evidence that it may improve your analgesia for intrascalene block in shoulder surgery. So if a catheter approach is not feasible in your setting, consider using some of these. I would caution though that for dexmedetomidine, as you know, can cause bradycardia, hypotension, and sedation. And for shoulder surgery, when you're already in a beachhead position and you give a nerve block in the intrascalene, I'm always worried about bradycardia due to the benzodiazepine reflex. So I typically don't add dexmedetomidine in the shoulder surgery for this setup, but I would use dexamethasone, especially if I cannot put a catheter. So in summary, there are more and more studies looking at blocking distal to the intrascalene for shoulder. Some of these you can do surgery. Some of these you can place catheters. They all seem to have better respiratory function compared to intrascalene. And some of these had comparable analgesia. Some of these had not as good analgesia, but the difference doesn't seem to last very long post-op. So do consider these other regional anesthesia options for your shoulder surgery. For me, my typical approach is I do a superior trunk catheter and for surgical block, and I find that's the best balance of analgesia and be able to do a surgical block and then respiratory dysfunction. So that's it for my talk. If you scan the QR code, it will take you to a PubMed page with the abstract for all the papers I presented. And thank you so much.
Thank you, Dr. Wong, for a very thought-provoking presentation, fairly succinctly covered a huge topic. So we'll have questions towards the end. You can just type your questions in the QA box and we'll try to address the questions which are the most popular first. So if you're got same people asking this question, same question being asked by multiple people will be asked, we'll try to answer that first. Next speaker is Dr. Kwofie. Dr. Kwofie, do you want to start talking since we've already done introductions?
That's great. Thanks very much for inviting me. It's a real privilege, and it's great to see so many participants from around the world. We're going to talk about spinal anesthesia. This is my assigned topic, and I did initially feel that it was a little bit daunting. All situations, I don't even use spinal anesthesia in all situations. I don't think I can cover every situation, but I would like to cover some from the literature, and as well as with some from my own practice, and hopefully give you some tools to be able to better negotiate how to use spinal anesthesia to be able to deal with patients in your situation. My only real disclosure is that I'm associate editor for As Renews, but they don't pay me anything, so I don't think it's much of a conflict. I am an enthusiastic regional anesthesiologist, and I do think regional anesthesia is great for a lot of my patients, but I don't think I'm a zealot. So I would like to present hopefully something that I think is balanced, and I will be discussing some off-label use of medication. This is the summary of what we're going to talk about, but we will also come back to it in the end. To start with, so why are we talking about spinal anesthesia? Certainly spinal and general anesthesia, modern spinal and general anesthesia are generally both quite safe. But as an example, this study in particular was an international consensus of recommendations. They were looking at hip and knee arthroplasty. They looked at 94 different studies and looked at all different kinds of complications, including pulmonary, DVT, infections, blood transfusions, etc. And what they found was that on review of the evidence, that between neuraxial anesthesia and general anesthesia, it was either a wash or that the benefit was favoring neuraxial anesthesia, with the exception of urinary retention. And on the whole, they recommended that neuraxial anesthesia was the best care for most patients when it was indicated. And I think that holds true for a lot of other surgeries as well. And there are a lot of different surgeries that can be done under spinal anesthesia, really any infraumbilical surgery. I would say that's for the most part less than 3 hours. And hopefully that has a predictable case duration, allows you to optimize the technique better. Of course, there's contraindications, including coagulation issues and potentially patients with severe fixed output syndrome. But that's a lot of patients. So why not use spinal anesthesia? And when I talk to a lot of colleagues, both anesthetists and surgeons, I think there's a feeling that somehow spinal anesthesia might be inefficient, either in the operating room, or that it might cause inefficiencies or delays in PACU for patients. And I just want to address this a little bit. And if you'll stay with me, I recognize that this is not to scale, it's a bit simplistic. And in fact, I don't even really love this terminology when talking about OR efficiency, but it's what's used in the literature a lot. If you look at the total OR time and you include the induction, the surgery, and emergence, you could loosely describe that as anesthesia controlled time with the induction and emergence, and the surgery controlled time. So there can be some overlap in these things. And when you're talking about serial processing of general anesthesia, all of these things are grouped into the OR time. When you're doing serial processing of spinal anesthesia, even if I would say that on occasion, sometimes the induction period might be a touch longer in some cases with spinal anesthesia, you make up for that time partially or wholly by not having any emergence time. So as soon as the case is done, the patient rolls out of the operating room. And people often forget about this benefit and efficiency, which I think in many cases favors anesthesia or is at most a wash. And in our own institution, we actually amplify on this because we do most of our spinal anesthesia actually in a regional anesthesia block room. And we actually have a whole separate team doing the spinal anesthesia. So when the patients arrive to the OR, they're ready for surgery. And when the surgery is done, they leave immediately and the room's getting cleaned up. So parallel processing can really amplify these efficiencies. So all of this induction is released from the operating room time, and these efficiencies are amplified when you have multiple rooms running. And even with multiple teams running, my colleague, Dr. Bailey, did a wonderful cost analysis looking at both anesthesia time, OR time, which were decreased at no increase in cost. So there's a lot of benefits to be had there. But still, you can have these inefficiencies, and we had these in years past with patients that were delayed, inpatients that were in PACU for hours and hours waiting for their spinals to resolve. We stopped doing that about 10 years ago, and we have a protocol where patients whose block has resolved to T10 or lower, has resolved 2 segments, they're hemodynamically stable and otherwise recovered, those patients go to the floor, and there's a standard template for their monitoring. The patients don't have to wait. And we can continue doing cases and have efficiency in the PACU. So spinal anesthesia, in many cases, I think is great patient care. It's efficient, cost effective. Some would even argue that it's good for the planet. So it's been debated in some studies. I'm not going to go into it here. You're left with which local anesthetic drugs that you can choose from. And I know there's a lot of folks that are here internationally, but from our own experience in Canada, a lot of people would argue that here, really the only game in town is hyperbaric bupivacaine, because it's the only local anesthetic in Canada that is approved by Health Canada for spinal anesthesia. And a lot of other medications are packaged like this isobaric bupivacaine that we use frequently. And when you flip it over, you'll notice a few things. One, it says that it can be used for nerve block, epidural anesthesia, and it's preservative-free. That's important. It means it doesn't contain methylparaben, which is antifungal, or metabisulfite, which is a stabilizing agent, because those can be neurotoxic. It does specifically say that it's not for spinal use. And some would argue that actually it's indefensible to be able to use this. And if there was a complication that you were brought to court, how would you defend yourself when it says right on the vial, not for spinal use? I would argue that this drug and many other local anesthetics, and all the ones that we're going to talk about today, have actually been used for decades and have decades of safe use with them. In this case, the drug obviously hasn't been approved by regulators for spinal anesthesia, not so much because of safety, but because it will require more packaging. So I think you can safely use this drug, but there is one large caveat, which is you have to be familiar with the dosing, because obviously an entire ampule here, 100 milligrams of bupivacaine, would be lethal if administered intrathecally. So you have to know that you have to be familiar with the drug that you're using, as well as the concentration. So if the only game in town was bupivacaine, we might have a problem. And a lot of folks have tried to deal with trying to use bupivacaine in a setting of ambulatory surgery, and really have tried to bring the dose lower and lower and lower to lead to a profile that is more consistent with efficiently getting patients out of PACU. This was a meta-analysis of 23 studies looking at patients getting low-dose bupivacaine for ambulatory surgery, and they were trying to extrapolate getting bupivacaine down to a profile where they could have resolution of motor function within 300 minutes. That's 5 hours in 95% of patients from the time of puncture. And they found that the dose needed to do that was 7.5 milligrams. And I think even that is not great as far as recovery for ambulatory surgery. And when they tried to get the doses down to 5 milligrams or lower, they started having very high failure rate, which is not ideal. The one area where low-dose bupivacaine has been particularly helpful, I think, is saddle anesthesia. This is a technique where you're administering a hyperbaric local anesthetic. It doesn't have to be bupivacaine, but in many cases it has been. And you leave the patient sitting for 5 to 10 minutes. You have a rapid onset, you get a dense block, and you can get earlier mobilization when you use a lower dose, which is dependent. But the big benefit of saddle anesthesia is you get very little hemodynamic effect. So this is very great for sick patients who are having low urological or anorectal procedures. The caveat to this, I think, and this really was a method of choice for many folks, including myself, for patients having prostate resection, but I would say that some modern prostate resections, like laser enucleation procedures, can be very long, 2 or 3 hours or more. So I think these techniques sometimes have to be used with caution and a good knowledge of what surgery you're using. There are a lot of drugs that are available. This is my own table that is a synthesis of the literature and my own experiences. I don't have any experience with prilocaine. That part's taken from the literature. The rest is sort of my own experiences, as well as the literature. There's some common concentrations, though I know there are many concentrations of these drugs. These are frequent. The low dose, I would say, is roughly the dose that's required for a reliable T12 block. The higher side dose is to try to achieve more of a T6 block. The time of surgical anesthesia on the low side would be, what you'd expect from a lower dose, whereas the higher side would be what you'd expect from a higher dose. I do say that when I'm trying to decide what is an appropriate dose for anesthesia, I do tend to dose up a little bit in folks that are younger and folks that are at extremes of height above 6 foot, 6'2", and I tend to dose lower in elderly patients, patients that are obese, or patients that are extremely short, less than 5 feet. This was a great study looking at knee arthroplasty and ambulatory, trying to get patients ambulating early with mepivacaine or either hyperbaric or isobaric bupivacaine. And mepivacaine was very helpful at getting patients ambulating within 3.5 hours of needle puncture compared to isobaric and hyperbaric bupivacaine. And in my own practice, the biggest problem that I find with bupivacaine is not just that on average that there is an increase in or delay in return of motor function, but that the standard deviation is so large that you'll have these long outliers and folks that will have blocks that will last for 8 hours or more, which causes big problems in terms of recovery, particularly when it comes to ambulatory patients. And with the increased number of patients that are having ambulatory, particularly total joint surgery, I think this is important. This is a very recent, actually, pre-pub study comparing mepivacaine, GA, or bupivacaine spinal anesthesia, and they actually found that mepivacaine led to a better recovery profile than both bupivacaine spinal anesthesia or general anesthesia, with less PACU time, lower pain scores, less opioid use, and earlier recovery of urination. And on day when we're talking about advocacy for regional anesthesia, I think it's important to highlight something that was a big impact on the Canadian anesthesia team. And this was a survey by my colleague Jennifer Zerb. That's her there. She was really inspired by the goal of trying to avoid aerosol generating medical procedures in early time after COVID, and still trying to get ambulatory surgeries done. And the fact that chlorprocaine had been removed from the Canadian market in 2012, though it was still available to our neighbors to the south in the United States. And she used this survey that she published in Canadian Journal of Anesthesia to advocate and achieved at Health Canada to have a no objection to now allow import of US labeled chlorprocaine into Canada. So I think this just shows that advocacy in regional anesthesia can really work and have a massive impact for patients. Why is chlorprocaine important? This is just one study that's an example. There was 302 patients that had 40 milligrams of chlorprocaine. They had no urinary retention, very early time to urination, and rapid discharge from hospital. And I think I have used chlorprocaine. Our routine, I would say, is for total joints, is to use mepivacaine for outpatient arthroplasties. I will say for this 40 to 60 milligram dose, 40 milligrams I find is a little bit on the thin side personally. I usually use 50 or 60 milligrams for knee arthroplasties, or 60 or 70 milligrams for hip arthroplasties. But I think it's excellent. I have used in selected patients hip arthroplasties and knee arthroplasties with chlorprocaine, which is incredibly fast, but I only use it with the surgeons that are the very, very fastest, that can reliably complete surgery skin to skin in 60 minutes or less. It's hard to talk about fast-acting local anesthetics without talking about transient neurologic symptoms, or what's probably better referred to as transient radicular irritation. I think this was first recognized in the 90s at a time when there was a lot of patients that were having intrathecal catheters with 5% lidocaine that were getting cauda equina syndrome. It's a specific syndrome with radiating back, buttock, and leg pain that seems to have no other cause. Starting within 24 hours, it might last for up to 5 days, and it's really a diagnosis of exclusion. And there's a nice Cochrane meta-analysis, which you would think usually a Cochrane meta-analysis might be the end of the story. They looked at 24 studies. They found that roughly the incidence was 10 to 20% in the worst offenders, which were lidocaine, chlorprocaine, and mepivacaine, and least in bupivacaine, levobupivacaine, prilocaine, procaine, and ropivacaine. But there's a but, and it's a big but. The evidence here was quite, the quality of the evidence was quite low. And when you look at the literature, and I recognize here that this is a bit of cherry picking, but it really makes you think. The first study is a study looking at hyperbaric bupivacaine versus isobaric mepivacaine, 32 patients per group. They found no TNS. Bupivacaine is supposed to be a terrible offender. The second was looking at 261 patients, lidocaine versus bupivacaine. Lidocaine is supposed to be the worst offender. They found no TNS. The third one's chlorprocaine, also supposed to be a terrible offender. 23 patients per group, no TNS was found. The last study actually was looking at bupivacaine versus mepivacaine. They said they actually found 2 cases of TNS, but when you look in detail, one was a dural puncture headache and the other was a foot drop that lasted for 4 days. So they didn't even know what TNS was, and I don't really blame them because the name doesn't really explain what it is, and that probably leads to part of the confusion. In fact, a lot of the studies that are in that review really just looked at surveys to the patients where they just asked them whether or not they had back pain radiating to the leg without looking at anything specific, which is difficult for a diagnosis of exclusion. This study is, or it's not study, it's a retrospective review of 679 mepivacaine anesthetics by a great group at Toronto Western, and they said they only identified 1 case of TNS. How can this be? When you look at this study, it was actually a randomized control trial with mepivacaine or lidocaine, both some of the worst offenders apparently, 84 patients, but specifically, they asked the patients and examined the patients, looked at patients to see if they had isolated back pain with point tenderness that wasn't TNS or non-radiating back pain and other causes. And what they found was no TNS, even though this was their primary outcome. And I think this really means that the whole, certainly TNS is an issue. We have an extensive experience with lidocaine, mepivacaine, and chlorprocaine. I'm aware of 1 case of that really sounded like TNS, but it's actually pretty uncommon, I believe, and I'm not sure that the literature reflects that, in part because of how it's reported. And really what it's called, I think that the name causes confusion. Additions to spinal anesthesia, such as lipophilic intrathecal opioids like sufentanil and fentanyl, are very common, and they can be used to increase the quality of the block, especially when visceral pain can be involved, to facilitate really low doses of spinal anesthesia, though I have to say I'm not a fan of that when we have fast-acting and offset local anesthetics. But when you do give opioids in the spinal anesthesia, you increase urinary retention, pruritus, nausea, vomiting, and you delay discharge by about 30 minutes on average. So I don't use this in patients, particularly in orthopedics, when there's not a visceral component. I just want to touch in the last minute about spinal anesthesia for challenging patients and really the importance of ultrasound. And I think this meta-analysis of 31 studies just confirmed the utility of ultrasound for finding the best interlaminar level, the depth, decreasing needle passes and technical failure with some small increases in time. But I think in the context of time, I think it's important to think about the anticipated difficulty. And this is just a schematic of my opinion of the fact that when you don't predict difficulty, ultrasound may cause increased procedural time. But when you do anticipate difficulty in patients that have previous spinal surgery, patients who are obese, or patients that have scoliosis, that ultrasound really pays dividends in the efficiency of the procedure. If you don't have familiarity with neuraxial ultrasound, this is an excellent article from ASBR News by three of my great colleagues. It has some of the best images and explanations on the subject. It's a free resource. It's not behind a paywall, so it's available to everybody. These are two excellent videos that are available from my colleagues Jeff Gadsden and Jin Chin in Toronto. I think they're excellent learning resources for you or for your trainees. The last thing I want to say is specifically about scoliosis. If you use your ultrasound to be able to visualize the midline and create an image that is symmetrical with your ultrasound, really ultrasound resolves scoliosis, and it turns it from a complex puzzle into nothing more than a nuisance. And I think it really supercharges our something that we already do really well. In obese patients, I think that having a spinal process view allows you to know where the midline is, and it also allows you to measure the depth of the spinous process, because our spine is essentially the same regardless of the size of the patient. And you know, if the depth of the spinous process is more 3.5 to 4 centimeters, you might need a longer needle. And though you can use things like a 22 gauge needle, which I use fairly routinely in difficult spines, in young patients that are high risk for dural puncture, I think a nice technique is to actually use a normal length 20 gauge spinal needle with a long 25 gauge needle, which increases the rigidity of the 25 gauge without actually using the 22 to puncture the dura. I advanced it about half to 3/4 of the way in these obese patients. Then I put in the 25 gauge needle and advance them together to ensure that I'm piercing the dura with only the 25 gauge needle to decrease the risk of dural puncture headache. The last thing I'll close on is the importance of learning, going beyond the midline technique to a paraspinous technique or a paramedian technique. I don't have time to discuss it in detail, but this article just came out in the British Journal of Anesthesia Education, and it's freely available as one of the editor's choice articles from Ki-Din Chin, and I highly recommend it. In summary, in closing, I just say it's important to select the correct drug for the correct patient and the correct context, be it ambulatory or not, that this provides great care for patients, that it can be very efficient, lead to earlier discharge. When you're using fast-acting local anesthetics, it leads to less urinary retention, potentially even than general anesthesia. You don't need to add opioids unless there's a visceral component you're trying to do a low-dose technique. And though TNS is real, it probably is very infrequent. It's something we can warn patients about, but it shouldn't stop us from using very efficacious medications. And using pre-procedural ultrasound can really supercharge the efficacy and efficiency of your spinal anesthesia technique. And thanks for your attention.
Thank you, Dr. Kwofie, for a very extensive and well-covered talk. I have to say, I think we agree on a lot of things as opposed to what our colleagues say about us, including a lot of things which were mentioned in this talk. There's a lot of interesting questions in the chat box Q&A. So we will try to address them towards the end, and we'll try to answer them as well. So yeah, a very, very fascinating topic, especially in days of outpatient hip and knee arthroplasties. So without any further delay, let's welcome Professor Vivian. Do you want to start sharing your screen, Professor?
Thank you very much. Thank you, Vishal. So thank you for inviting me for this very great event to celebrate the first World Day of Regional Anesthesia and Pain Medicine. Good morning, good afternoon, good evening, wherever you may be, welcome. And today my talk is Regional Anesthesia and Trauma. My name is Vivian. I'm a clinical professor at the University of Calgary, and I'm also a practicing anesthesiologist with special interest in regional anesthesia and acute pain at the South Health campus. Calgary is, can't advance my screen. Excuse me, technical challenges. Yeah, Calgary is a beautiful city, and it has the Rocky Mountains just close by, just down the doorsteps. Very beautiful. But then the winter the roads can be quite treacherous and very slippery for drivers, pedestrians, cyclists. And by the way, I wasn't driving while taking this photo. So I do have some disclosures. And here are the objectives of my talk. So what causes the most trauma hospitalization across Canada? Well, 2 decades ago, it was falls. 2 decades on, falls is still the leading cause of injury hospitalization across all ages, especially in the elderly. It is very costly as well. It's costing Canadians almost $30 billion every year. That's $80 million per day and more than 200,000 hospitalizations. It also stole more than 300,000 years of potential lives saved. So it is a big problem. So how are we doing in treating pain in these trauma patients when they come into the emergency department? Well, not very well, I'm afraid. 74% of these patients discharge from the emergency department with moderate to severe pain. And this study from South Africa showed that up to 2/3 of these trauma patients had to wait up to an hour for pain relief in the emergency department. Now, the risk factor that's most predictive of post-trauma chronic pain is the acute pain at the time of the injury. And the odds ratio is between 2.4 to 11.2. So what can we do as regional anesthetists? How can we help? What are the types of trauma that really matter and affect outcomes? Here are a few. And let's focus on the first 3 that matter and affect outcomes. So, rib fractures. The number of rib fractures directly is related to the associated mortality. So if one has 6 or more rib fractures, then the mortality can be as high as 34%. And in the elderly as well, they can get up to 10% mortality if they have a rib fracture, and up to 30% of respiratory complications. Not surprising, really, because rib fractures are very painful, so they can barely breathe. And especially in the elderly, they get atelectasis, pneumonia, and then intubation, off to ICU. And chest physio is not that effective because they are in a lot of pain. So really, the goals of treatment is to minimize the pain and therefore minimize the respiratory compromise. And of course, in doing so, you don't want too much side effects from the treatment either. And of course, as well, avoid complications, for example, pneumothorax or local anesthetic toxicity when you're treating these patients is very important. So what are the types of regional anesthesia for rib fractures? Well, in the old days, thoracic epidural used to be the gold standard. I mean, it's great if they have bilateral rib fractures. But now we're spoiled for choices. So which one is better? This is a retrospective cohort study of about 3,000 geriatric rib fracture patients, comparing thoracic epidural and paravertebral blocks. And please go ahead and scan the QR code to see the study or the abstract of it. So what did they find? no difference in mortality and delirium, and the longer-term outcome of 90-day respiratory complications, mortality, and mechanical ventilation. How about comparison between neuroaxial or paravertebral block against fascial plane blocks like serratus anterior block? Well, this retrospective study, a small one, demonstrated no difference between groups in reducing pain score in 39 critically ill patients with rib fractures. And does timing matter? This retrospective cohort study of 199 rib fracture patients showed that if you do erector spinae plane block after 48 hours after the trauma, the respiratory complication and the intensive care length of stay worsened. But there didn't seem to be any additional benefit in rushing to do an ESP block promptly within 24 hours either. And by and large, many literature show where epidural and paravertebral block shines are better respiratory function, less delirium, and less mortality. So why don't we do it for all patients? Well, because times changed. Many trauma patients are now on anticoagulants twice a day. And positioning these patients may be difficult. As I say, rib fractures is very painful. And they may not only have rib fractures, they may have other fractures as well. And then C-spine precaution, and of course, like spinal cord injury, you name it. And these techniques tend to be technically challenging as well. And of course, informed consent for invasive procedures like epidural if the patients are intubated and sedated on ICU, very challenging. And performing epidural on sedated patients, well, contentious. That's for another lecture. So we need to look at alternatives. Erector spinae plane blocks, serratus anterior plane blocks, or pectoralis plane blocks. These are great blocks if you don't need to turn the patients because you can do them with the patient in supine position. But bear in mind that they are large volume blocks. So you do need larger volumes and be aware of local anesthetic toxicity, especially if they have risk factors. So which block shall we do? Well, here's when we need to have a look at the risks and benefits and treat each patient individually. Say if a patient has bilateral rib fractures, you say, great, yeah, thoracic epidural, yeah, let's go for it. And then you find out they are on anticoagulants. So not so great. And of course, if you haven't done the paravertebral block before, this will not be your first paravertebral block. So really, a patient-centered, individualized care. And it really depends on the circumstances of the individual patient and yourself, your skill set. So let's have a look at hip fractures. How are we doing in hip fracture patients? Well, the studies more than a decade ago show that the pain scores were terrible, they were under-medicated, and then they suffer from opioid side effects. And because they're elderly, so between the opioid and the trauma itself, there's high risk of delirium. A decade on, thanks to regional anesthesia, we're seeing more and more nerve blocks being done, even by emerged docs. So the pain control is better, reducing opioid consumption, better pulmonary function, and reduce inflammatory markers. How about reimplantation and revascularization for trauma amputation? Well, the advantage of sympathetic block from regional anesthesia dated back to 1979 for these patients. Now, this is a small observation study of just 19 patients, but they show that the reoperation rate due to vascular compromise was 0% in the continuous supraclavicular block group versus 29% in the systemic opioid group. Controversial issues. Well, I can think of one, compartment syndrome. I don't know about you, but I have had multiple discussions with the orthopedic surgeons about compartment syndrome and regional anesthesia. This is always contentious because the very symptoms that's used for diagnosis is the very thing that we're trying to treat. And of course, prompt diagnosis is vital because there might be dire outcome and potential litigation problems. But it's relying on clinical diagnosis of the 5 Ps: pain, paresthesia, paralysis, pallor, and pulselessness, really a good way to diagnose acute compartment syndrome? Well, the answer is not really. It turned out that the predictive value is only 21%, and is even less if they're neurologically impaired. For example, obtunded by opioids. Now, previously, it's been proposed that the ischemic pain transmits through a different pathway than the common sensory and motor nerves that are targeted by our nerve blocks. So really, the pain will break through nerve blocks. And this randomized control trial showed that the injection of local anesthetic around the femoral artery to block the perivascular sympathetic fibers reduced the incidence of tourniquet pain. So shall we block or not? Well, if clinical diagnosis has such poor sensitivity and that ischemic pain will break through the peripheral nerve block and unmask in early acute coronary syndrome, then opioid-based analgesia may obtund the patient and making clinical diagnosis even more challenging. Clearly, we should block, right? Let's do a randomized control trial. Not so fast. I don't think we'll get through ethics. So a better way, perhaps, is to review large registries and to compare the true risk of, compartment syndrome amongst all these different, the true risk of analgesia modalities, which we're still waiting more of. So the debate continues, but the focus should be towards better monitoring, better patient selection, identify which patients are at high risk of developing compartment syndromes. For example, the anterior compartment is more, usually more affected compared to the lateral or the posterior. But then if you have high impact injury, then all compartments will be affected. And then treat them as individuals. And of course, communication is important between ourselves, the surgeons, and the nursing staff. Regional anesthesia does provide good analgesia without obtunding the patients and can actually improve early detection of acute compartment syndrome in trauma patients. So if they need it, have a discussion, see if they're warranted and do it. Now, how about other controversies in the regional and trauma area? Now, our prime aim, as I say, of providing regional anesthesia to trauma patients is to improve their outcome. So we need to increase their access to it. They need to be getting it. But then these patients come in at all hours into the emergency department. So shall we let the emerge doc do nerve blocks while keeping our motto, first do no harm? Potentially. I think it can be done safely, as demonstrated by the study in the Netherlands, showing that when emerge docs work closely with the regional anesthetists, then successful collaboration can happen. Now, we all know that performing nerve blocks is just not just identifying where the nerves are. It also requires good hand-eye coordination, as well as non-technical skills, like good communication with the patients, the relatives, and other healthcare providers. Sedation for the blocks if the patient needs them, if it's necessary, but not obtund the patient so that you lose the airway as well. Monitoring during and after the block, and be aware of local anesthetic toxicity and its treatment. So you don't just do a block and then walk away. clear documentation is very important. And I should point you to this article, this Delphi consensus survey on effective documentation in regional anesthesia, which is supported by both Asra Pain Medicine and Ezra. And last but not least, decision-making, very important. And it comes with experience too. But we need to know when to block and when not to block. So really, the key to success is to develop a robust training pathway and including the regional anesthesia experts, as well as champions in the emergency department, because they need to play a part too. They need to be dedicated, motivated. Have a clear practice protocol, including steps to prevent complications. And lastly, this process needs to be reviewed and refined to ensure good quality of patient care with minimal complications. So, in conclusion, of course, we need to understand what types of trauma regional anesthesia has an impact on. And then there will always be controversies in this area. But it is important to collaborate and work out a solution that is in the best interest of our patients. As Henry Ford said, coming together is a beginning. Keeping together is progress. Working together is success. So how are you going to bring regional anesthesia to your trauma patients? Thank you.
Thank you, Dr. Ip, Professor Ip. I stand corrected. That was amazing. I love the line from Henry Ford. That was very impressive. You know, we have to work together. Personally, I would not want to be the surgeon discussing regional anesthesia compartment syndrome with you. I would be like, do whatever you want to. Yeah, that's an interesting topic. Maybe we should have discussion in the Q&A about the compartment pressure monitoring, because that's one of the controversial areas. And if someone has an experience in that, that would be good to know. There's a lot of Q&As coming as well. So we'll try to answer them, and we're slightly over time, but we'll stay back after the talk and answer any questions for the audience which are remaining pending. But I think we are doing a reasonable job at answering them online here. So Dr. Shah, Dr. Ushma Shah, you're next. Thank you so much. If you want to start sharing your slide, then I will mute my mic. Thanks. Looking forward to your talk on pediatric anesthesia.
Hello, everyone, and welcome to this First World Regional Anesthesia Day. And thank you for spending this Saturday afternoon with us. Without much delay, I'll be talking about the pediatric regional and how we can achieve our best for our little patients. So the objectives for today will be to review the unique considerations of pediatric regional, which are different as compared to our adult patients, summarize the current evidence for the safety of regional and pediatric population, and explain the importance of an interprofessional team, which makes a very big difference in our pediatric population for the success of effective pain management. Children are different from adults, and neonates are different from children. This is extremely important because there's difference in both neuroanatomy, neurophysiology, and pharmacological considerations when we are talking about neonates, infants, children. We all are aware about the difference in neuroanatomy, so I'm not going to spend much time there. But what I want to specifically stress on is a neurophysiology. So pain perception has been shown to be intact after 25 weeks of gestational age. So all our premature infants and neonates do feel pain. They have greater receptive field of neurons, leading to a poor pain localization. At the same time, They have immature descending inhibitory pathways. As a result, their nociceptive inputs are unmodulated. They have incomplete myelination of nerves. This is important while doing a nerve block in these little ones. The neurohormonal stress response, which results because of an uncontrolled or ineffectively treated acute pain, may lead to chronic pain as they grow up and also behavioral issues. Hence, meticulous and preemptive management of acute pain is extremely important both in infants and in children. In terms of pain management in children, before the regional era, most commonly used was opioids and other non-opioid medications. With opioids, we have to be extremely careful in neonates. They not only have an undeveloped renal function and hepatic function, but they do have an immature blood-brain barrier as well. This, in combination with their ongoing illness and prematurity, will have all kinds of altered pharmacology and high risk of respiratory depression. So why not consider use of regional in all these infants and neonates to help with the pain management, at the same time minimizing the risk of respiratory depression? So the dictum should be, we should consider regional anesthesia for all kids, no matter their age or what surgery they are for. Consider use of truncal blocks for all procedures, including abdominal and thoracic procedures, laparoscopic procedures. Use of common peripheral nerve blocks, both upper limb and lower limb. Use of the newer blocks like pudendal nerve block and penile nerve blocks, ultrasound guided, for urological procedures. And obviously the gold standard use of epidural and spinal neuraxial block where it is relevant or where it is a bilateral surgery. So there have been recent studies of use of quadratus lumborum block for neonatal intestinal surgery as a part of enhanced recovery protocol. So this was in a case series where 10 neonates undergoing abdominal surgeries received bilateral QL blocks with ropivacaine along with an adjuvant, and they all were extubated at the end of the procedure. This is possible only because of the regional technique, because we minimize the use of opioids during the surgery, which enhances and enables us to extubate them at the end of the case. Use of TAP block for all postoperative analgesia in neonates and infants. Again, a retrospective analysis of a case series in neonates and young infants, where 34 neonates, including 11 premature infants, either received TAP block, unilateral or bilateral, and 29 patients were extubated at the end of the surgery. And most of them required no additional post-op analgesia in the first 24 hours, and hence they had a better outcomes. Use of thoracic paravertebral nerve blocks should also be considered in pediatric patients. This is one of the older studies, almost 8 years ago, where they saw the safety and clinical experience in all sort of age groups, from infants to adults. This data was obtained from 2,390 paravertebral nerve blocks used for either thoracic or abdominal surgeries, both open and laparoscopic. They use either single shot or catheters depending upon the surgical requirements. And there was only one case of local anesthesia systemic toxicity in all of these patients. Again, it tells us that they are safe when used effectively and with proper expertise. Use of erector spinae block on postoperative pain in undergoing surgery. Again, this was a systematic review and meta-analysis where there were 7 randomized controlled trials in 379 patients. They compared no block with erector spinae plane block, and all of them had reduced pain scores both at the 12th-hour mark and at 24-hour mark, thereby decreasing their opioid requirements and leading to better outcomes. The question now lies, is it safe to do regional anesthesia? Because we are all aware that in pediatrics, we have to do either under deep sedation or under general anesthesia. So how safe is it then? The Pediatric Regional Anesthesia Network has safety data from around 100,000 blocks, and they found no permanent neurological deficits. The risk of TNS, though real, was documented 2.4 in 10,000. There was only one case of epidural abscess, one case of epidural hematoma, and there was a small risk of catheter failures. So overall, it is safe to do pediatric regional anesthesia in pediatric population if you have the training and you take all the precautions. What about LAST, or local anesthesia systemic toxicity? Again, if you pay strict attention to total dosing in terms of milligrams per kilo, or in case of infusion, milligram per kilo per hour, you can minimize the risk. In case of PRAN database, the potential toxic dose in neonates was seen 6% during intra-op loading of the epidural catheters, but the highest chances were seen in post-op, mainly because of the infusions going on for hours and they crossed the milligram per kilo per hour dosing. So overall, the incidence documented in literature is 0.7 in 10,000. Transverse abdominal plane blocks is also highly recommended in neonates and infants undergoing surgeries, but again, is it safe? We all know that TAB block is a volume block and it needs a good volume to achieve the block. But at the same time, we have to be mindful of the dose we use to achieve the volume. So this was an observational study where they used ultrasound guided TAB block with a total volume of 1 ml per kilogram of bupivacaine. And they obtained blood samples at different points to see if the local anesthesia reached toxic levels in the plasma at all. The highest limit was seen at 30 minutes after the block, and it was still lower than the potentially toxic doses if you use the total volume and the total concentration appropriately. This is again the data from the multi-center safety analysis of 1,994 cases of TAB block. And as you can see from the diagram, for that particular weight, the dose range has a wide variability in terms of what people have used. So again, the median range for the dose was around 1 milligram per kilogram, but there were outliers almost up to 2.2 milligrams per kilogram, which was used to achieve the TAB block. So as long as you remain in the dose range, TAB block has been shown to be safer. The overall complication, however, reported even in this big study was only 0.3%. So what is the safe dose of local anesthesia for pediatric regional? So recommendations have been given for both European Society and American Society together in terms of the dose range for use of local anesthesia for pediatric population. They have recommended to keep the dose around 2 to 2.5 milligrams for caudal epidural, and to decrease the dose if you're using for lumbar and thoracic epidural to 1.7 milligram per kilogram. And even further lower if you're using continuous infusions. Depending upon the age, be mindful of the dose. So it's not that one size fits all. You have to be very careful with the amount of concentration and the dose in this pediatric population in order to achieve safe regional anesthesia. I just want to go through the Swiss cheese model of pain. So there are multiple factors which go in why a child feels the pain. Unless you treat multiple ways, it'll be difficult to achieve effective pain management. So what is this 3 models or the 3 parameters we should be aware of? First is the psychology of the child. How anxious is the child? How anxious are the parents? Because an anxious parent will make the kid anxious for the surgery. Secondly, how mobile is the kid? And encouraging mobility after surgery is extremely important to help in early recovery of the child. And thirdly, pharmacology and regional anesthesia will play a role. So it's extremely important to use a 3P model of pain management for pediatric patients, which will include treating and talking to the patients and their parents as a whole, decreasing the anxiety around the perioperative period, and a good perioperative education about what to expect, getting them early mobilization to help with the pain management as well, and pharmacology is one part of it. So interprofessional team plays a very important and a dynamic role for acute pain management in pediatric patients. And who will be a part of this interprofessional team? So patient is at the center of this team, along with his family. And then you have to include the nurse, the physiotherapist, the social worker, the child life, and in the end, the surgeon and the anesthesiologist. For some patients, a psychologist may be helpful if you have already identified red flags of previous distress or previous anxiety issues. So takeaway points for today would be that large data sets support the safety of regional techniques in children when sedated and under general anesthesia. Local anesthesia systemic toxicity is a rare complication in pediatric regional if carefully done by keeping in mind the considerations of the dosing and the technique used, and consider use of regional blocks and newer plain blocks as an alternative to neuroreaction blocks. Thank you.
Thank you so much, Dr. Shah. There is a few questions, mainly about spinal anesthesia in kids. We'll come to that, but I'll let you have a look at the chat box while we start the Q&A session with Dr. Wong. There's quite a few questions on shoulder replacement. Dr. Wong, are you still there with us? And then we have a few questions regarding outpatient shoulder surgery, how to deal with that. So we'll just go in order of, I know you answered a few of the questions already on the chat box, but anything in specific you wanted to actually talk and express your views on?
Yeah, for outpatient shoulder surgeries, we do both our scope, rotator cuff, and open shoulder. Most of them are outpatient, go home the same day. So we treat them fairly similarly. We are lucky that we have a very well-established ambulatory catheter program. So we'll do some kind of catheter, usually intrascaleral or superior trunk catheter. And most patients have a surgical block and sedation, and they go home running a continuous ambulatory catheter for 2 days. If it's just a shoulder scope for like a diagnostic scope or more simple shoulder surgery that's not as painful as a rotator cuff, we do a single shot block and instead of a catheter, and sedation as well. If you're in a setting you cannot place a catheter for whatever reason, I would suggest adding some additives and make sure your patient is well aware of the phenomenal rebound pain. Start the analgesic early, tell them to start taking pain pills even before they have pain, or fairly as soon as they start having some sensation back, get the pain pills and the pain pills in.
Can you speak up a little bit, Dr. Wong? I think.
Okay, sorry. Yeah, so remind your patients that it's the phenomenal rebound pain. Take the pain pills early, and I tend to, one of my little tricks that I tend to give a little bit more local anesthetic if I do single shot block for the first case of the day rather than the last patient, because the patient don't care how long the block lasts. They care that the block lasts till tomorrow morning. So as long as they can sleep, they're much happier. So for the first case of the day, I do my best to inject as much as possible, give the additives that would help, versus the last case of the day, I'm a little bit more restrictive if there's a questionable risk benefit. But I'd be interested to see what the rest of you guys are doing for your ambulatory shoulder surgeries.
Yeah, it really depends on your setup, isn't it? In your setup, looks like the catheters are much more easier to do. In a lot of the community hospitals, they're challenging to do. Well, we'll come back to the topic of additives to prolong the block, because there was a few questions on dexamethasone and liposomal bupivacaine. But let us just hear a little bit from Dr. Kwofie. If you have, there's a lot of chat going on regarding on the Q&A box regarding isobaric versus hyperbaric bupivacaine. And there was a comment from Dr. Chin about the distribution of isobaric. Looks like the world is divided in two halves about hyperbaric versus isobaric bupivacaine, and also mepivacaine. And people are asking about additives for if it's needed or not. Kwesi.
Sorry, I missed what I didn't see that specific question in the box, and I missed what is the question.
The question is mainly about the choice between isobaric and hyperbaric bupivacaine. And some people suggested, including Dr. Chen, that the distribution of isobaric bupivacaine can be unpredictable. And he was also talking about hypobaric by adding some saline to it as well. Those are all homemade recipes. Any thoughts on that?
So I recently read Dr. Chin's opinion about hypobaric bupivacaine, particularly when it came to a Taylor approach, an L5S1 injection, which can sometimes end up being a little thin. And I don't have any experience with that. I can't comment, but I did read it with interest. When it comes to isobaric and hyperbaric bupivacaine, I think of hyperbaric bupivacaine as kind of giving you two chances. If I have a block that's a little bit thin and I assess it early, I feel like I can move it around a little bit. And you occasionally do get those blocks that are, one segment or two segments, a little bit thin. And it is my sort of anecdotal opinion that you can milk it. So I do prefer using hyperbaric. The benefit of isobaric, well, the difference, isobaric lasts longer. So if you really want to get a very long acting block, isobaric is for you. I agree that the distribution can be a little bit odd. The other time where I would choose isobaric, and I don't have evidence for this, but in patients that have very severe scoliosis, I worry that baricity in a very contorted spine might affect the distribution. So I tend to use isobaric for patients with severe scoliosis, but that's a very small subset. Beyond that, and very long procedures, I tend to favor hyperbaric bupivacaine because it's faster onset, and the fact that I feel I can direct the distribution a little bit.
Perfect. Well, come back to you about the question on unilateral spinals, which was there as well. But let's just hear Dr. Ip's views on compartment syndrome and compartment syndrome monitoring. Do you guys do some compartment syndrome monitoring in your setup and its value? And does the surgeons think that that's a useful thing if we are doing blocks in patients at risk of compartment syndrome?
Yes. So thank you. Now, the thing is with compartment syndrome, for the two schools of thoughts and different opinion between my orthopedic colleagues and the plastics colleagues. Orthopedic colleagues, somehow they don't believe in compartment pressure monitoring. They didn't think it works. Sure, because of it depends on what manometer you use. You may not get a continuous reading, and that the needle may be blocked, and then you may have a false reading. And the plastics team always use the needle manometer, and they always have the diagnosis that they didn't seem to bother about whether we block or not block. Now, that's the first thing. And secondly, my opinion is that, sure, we know that the clinical diagnosis is very of poor predictive value, and that we need to use, I'm not saying we don't use the clinical observation, but we use the clinical observation as well as other means. For example, use your monitor. So as you know, I'm a believer for multimodal monitoring with my nerve block, doing nerve blocks with monitoring compartment syndrome, the pressure. Then I think you can't just use an isolated one reading. Firstly, clinical diagnosis, use the gadgets that you have. I don't care whether you believe it or not, but the literature does say that the sensitivity is good. It depends on what gadgets you have. I mean, sure, you don't need to go to the top of the range near infrared spectrometry, but the plastics carry the needle manometer in the bag, so you can do that. But the trend is also important, and also if the patient is at high risk, that's why it's always think about the patient as well. Are they high risk? Was there a big impact trauma injury that they're high risk and that you need to pay more attention to them? For example, every hour you write down the order, nursing staff, please can you monitor the patient every hour, check on him every hour. Sure, you don't check on every single patient every hour because then the nurses will be doing anything else. But that's my opinion. Yeah, I'll be interested to hear others.
Yeah, looks like Dr. Wong's got some opinion there. Let him jump in. Then we'll come to Dr. Shah for spinal anesthesia for pediatrics.
I totally agree with Dr. Ipps in terms of the regional anesthesia and compartment syndrome. It actually makes no logical sense. If you don't block them, they have pain right off the bat. So their using pain as a monitor is gone right off the bat. And in fact, it's not a high number, but the 2 cases at my institution I'm aware of that had block and had compartment, both of them, the pain was the first presentation despite the block. So the evidence of ischemic pain travel in a different way, and it's not covered by the regional. And I think that's pretty legitimate in the limited experience that we have. So and if is really they really push for it, I would do a catheter. I would inject low concentration local anesthetic. That way they still have some sensation, but it's not a fully complete insensate limb. And then you can have the best of both worlds.
Yeah, I just find that it is these patients need fairly intensive monitoring, and whichever way it is, there's also reports of compartment syndrome being masked by PCA and opioids as well. So these patients do require more close look, and it really depends on your setup as well. Before I go back to Dr. Wong about dexamethasone in the blocks for shoulder, let me just get some views from Dr. Shah about spinal anesthesia for pediatric patients, because there was a question on that. What do you use and when do you use?
I think spinal anesthesia is excellent in skilled hands, and the only challenge is the short duration. We work at an academic center, and most complex neonatal and infant surgeries are done at an academic center. That means it's a teaching center. So none of the surgeries finish even before the 30-minute mark. So I think in our setup, we do not tend to use at all any spinal anesthesia because of the duration of the surgery. It's mainly a general anesthesia combined with some kind of a peripheral or a regional technique in order to achieve the duration at the same time post-op analgesia. But I would just put a caution in terms of people who are doing spinal anesthesia. It's a good technique if done under trained hands, and use ultrasound wherever you have, just to make sure your entry point is where it should be and not at a higher level where it can be damage to the cord or to the cardiac equine.
Perfect, thank you. Dr. Wong, about additives for blocks, for prolonging blocks, you said you want them to wake up. And also a question about liposomal bupivacaine that was on it, which we don't have in Canada anyway. So I'll leave that to you to whether you want to answer or not.
I don't want to get sued, so I'm not going to comment on liposomal bupivacaine too much. I didn't look into that at all because, like you said, there's no evidence it's not available in Canada. But in in my mind, any of these additives, I still prefer catheter just because of titratability. None of the additives, you can turn it off if you want to. When you give it, it has to last as long as it's supposed to last. Whereas catheter, you can turn it on or off, so you make it last longer or shorter. So in an ideal world, of course, catheter is still better. And then in terms of additives, I routinely use IV dexamethasone. We were doing that anyways for other things. We use it for many other cases, non-regional and regional. You know it's safe. You have you're gonna use that for nausea and vomiting anyways. It makes no sense not to give some. I do use preservative-free perineural dexamethasone. I know the literature is a bit controversial whether IV is just as good as perineural. I do find there is cases where I find the perineural dexamethasone lasts longer, but that's not completely evidence-based, I must say. Some of my colleagues use perineural dexmedetomidine quite routinely, and they tell me that it lasts even longer. I must say that I only periodically have used perineural dexmedetomidine because I worry about the bradycardia and the hypotension, and all of the blocks that I do, the ambulatory surgeries of the hypotensive or bradycardic or sedated, I can send them home. So I reserve that for specific cases.
Yeah, I agree with you. I don't see much role of perineural dexmedetomidine because dexamethasone is much better in terms of duration of analgesia and also reducing rebound pain. So I personally have started adding some perineural dexamethasone on patients at a high risk of rebound pain and severe pain. Sorry, Dr. Ip, you wanted to say something?
Just a word of caution. Bear in mind that, for example, if you're doing interscalene blocks, if you're putting adjuncts that will prolong the block, if they do have phrenic nerve block, you're prolonging the phrenic nerve block too. Just a word of caution.
Yeah, and also make sure that we use a preservative-free solution, dexamethasone, rather than the one which is commonly available, which has preservatives in it. Dr. Kwofie, back to you. I know you're busy answering all the questions online. People want to know more about spinal anesthesia, more about unilateral spinal anesthesia, and also mepivacaine additives, including dexmedetomidine. Looks like people want to put dexmedetomidine everywhere these days.
So unilateral spinal. So my take on unilateral spinals is this is really the same trick, trying to get the most out of a low dose of a long-acting local anesthetic, most commonly bupivacaine, trying to milk it to one side to try to keep the dose as low as possible. It might have some hemodynamic benefit, but I think in most cases, you know, whether I have to give a small amount of vasoactive drugs really isn't much of a benefit. And if I'm really trying to have the block kinetics and block resolution that I want, I'd rather use a medication that is going to give me more reliable kinetics. So I'd rather look at the armamentarium that I have, and my preference would be to use a shorter acting drug, whether it's mepivacaine or cloprocaine or what have you. If my goal is for ambulatory surgery, which is most of the time where these unilateral spinals have come into play. The other thing I would say is when you are using particularly hyperbaric local anesthetics for unilateral spinal anesthesia, it actually makes it more difficult for you to actually be able to assess the block, which I find is just quite a nuisance. So I prefer to have the patients supine or Trendelenburg, reverse Trendelenburg, rather than unilateral, because that makes the patient easier to assess. And I can't really see that. I'm not a fan of this idea of using really low doses of local anesthetic when we have better drugs that have better kinetics.
Perfect. I do agree with you that testing is really hard when you turn the patient lateral, and also putting them head down.
That's the unilateral question. The second question was about dexmedetomidine. So I specifically didn't talk about this, one, largely because I don't have any personal experience with it. And I do think that dexmedetomidine intrathecally is understudied, particularly in terms of safety. It doesn't have a long history of use with it. So I'm not particularly comfortable with doing that. I would go further to say that, again, because our armamentarium of drugs, at least potentially, is actually quite large, there are very few occasions, if I really want the longest duration of action, I'm probably going to use isobaric bupivacaine because it has the longest duration of action. If I'm looking for something that's longer duration than that, I mean, I might be able to put a CSE. To be honest, I'm probably, if I'm expecting the surgery to be longer than that, I'm probably not going to do the surgery under spinal anesthesia because I find trying to keep a patient still for 4 hours, it's just very uncomfortable for the patient. So unless there's a really important contraindication, that patient's probably going to get a GA in my hands. But why would I want that isobaric spinal to last longer than 3.5, 4 hours? To me, doesn't make any sense. I don't know when I'd really want to do that. But it's interesting. It does seem to have an effect in the limited literature that's there. Probably worth some more study, but I probably, even if it was well studied, wouldn't use it in clinical practice.
I agree with you, and I think people sometimes put all sort of drugs in spinal space, and even epidural, those should be considered sacred, and it just experimenting individually is not what I feel people should be doing. Should be using time-tested drugs rather than putting any drugs thinking that it might prolong. There was another very interesting question which came out on spinal anesthesia, which is very topical. So I'll stay with you, Dr. Kwofie, about NR fit. The question was about let me read it again. Equipment NR fit. In general, I think they're asking about whether we should be using that to prevent drug errors.
Sure.
And this is a topic of your interest, so I'll let you.
So I think that there are a lot of errors that can happen and a lot of problems that can happen by putting something that shouldn't be in the intrathecal space into the intrathecal space, and it really can cause a lot of harm. The question really is, does NR fit prevent you from putting something in the intrathecal space that shouldn't be there? And my answer is probably not. It does make it a lot more difficult to be able to, sometimes just to be able to conduct normal practice. I do think that having procedures in place, particularly not so much for spinal anesthesia, but particularly for epidural and epidural catheters, where only a small subset of people are allowed to connect epidural catheters, that epidural catheters are never left unattended where someone could inject into them. I think that's where you could make an argument for NR fit, but I think it's overrated, it's expensive, it's complicated, and I'm not a fan. But I do think policies and procedures to prevent complications is really, really important.
Perfect. Thank you so much. I have a reminder from CS, which says that please complete your evaluation forms to get the CME credit. There was also a question on chlorprocaine, which is repeatedly being asked about. People are not able to get that drug hand, which I can actually answer because I was on the paper where Jennifer did the survey, and subsequent to that survey, Health Canada made a special provision to import chlorprocaine from US because it's not probably cost effective for the companies to make chlorprocaine in Canada, but Health Canada allows importation of it. So if you have problems getting it, then please contact with your pharmacy. That Health Canada has allowed any Canadian organization to import chlorprocaine from US. It does sometimes need to be rebranded.
And if you have trouble, feel free to reach out to me, send me an email or DM me on Twitter or X, whatever they call it now. And I'll be happy to help.
Yeah, but I think it's a part.
But in Canada, it's widely available. Outside of Canada, I don't know if I can help much.
Yeah. The problem is that the pharmacies don't know how to get it. And that's the problem which the pharmacies also have to work on. They just don't say they can't just say that it's not available.
It is available though.
It is definitely available. I have to be respectful of people's time. We're almost half an hour above our time limit, coming to 2 hours now. But any burning questions that any panel members want to answer or talk about? Any of you itching to talk about? Ushma, you had not too much time to interact. Do you want to say a few last words about pediatric regional anesthesia, about doses and drugs? There was a few questions around it there. And also additives for peripheral nerve blocks for pediatrics as well. Those additives are the topic which people love.
I think for additives, I would say the same thing. Less is more in pediatrics. Keep it simple. Use just your local anesthesia and in low concentrations and volume to make sure you don't reach the local anesthesia toxic dose. IV dexamethasone just works fine, has been shown in studies to be effective. That's what we are using. We just use plain local anesthesia blocks. We, in fact, don't even use opioids in our epidurals. We try to keep it very clean regional technique so that if there's any complication, we know it is not due to regional and it's secondary to something else, or we can stop our regional infusions or blocks and then evaluate the kid. So we believe in less is more. No, we don't use any adjuvants at my center, and we just use plain low concentrations. In terms of concentrations, I would just like to say that 0.125 to 0.25, we usually concentrate only on sensory block, not a motor block for pediatrics, because anyway, the child is going to get general anesthesia for the surgery. So you don't need a motor block.
Perfect. Thank you so much to all the panel members and all the participants who made it and they joined us on a Saturday morning. We recognize that we were not able to answer all the questions, but as Dr. Kwofie said, please do get in touch with us via Twitter or email, and we will be more than happy to answer your questions. I'm going to just type my email address in the chat box there. And Kwesi, if you want to type in, and any of the other panel members want to type in there, that they're more than welcome to do that as well. But we do apologize. We cannot get to every question because there's so many questions, but thank you so much for joining us. And hopefully we'll have it again next year with the same time. Thanks.